Hello and welcome to my CICM Fellowship Exam tutorial on preparing for the HOT case, called Hot Tips to Ace Your Case. My name's Ollie Walsh. I did most of my training at Royal North Shore in Sydney before moving to Canberra 2 years ago and passing the exam last year in 2021. I know a lot of candidates don't have a good sense of how to prepare for the greatly feared HOT case. So I thought I'd share some of the lessons I've learned and the tips that I wish someone had told me a year ago. Some aspects might not resonate with everyone, but hopefully you can all learn at least one useful thing from this talk. And just to state the obvious, none of this is official advice from the College of Intensive Care Medicine. This presentation is deliberately different to other exam resources, of which there are many. I can't stress enough how much I think Ken Hoffman's video perfectly summed up what the HOT case is all about, and I highly recommend you all watch it. Jenny Wu has a simulated HOT case on a burns patient, and in particular her presentation and interrogation by the examiners is useful to new candidates. There are several other noteworthy presentations and blogs that are helpful, not least of all, the ever trustworthy Deranged Physiology. Here's the list of ones I found. I'm sorry if there are any good resources I failed to mention. I'd like to briefly go over the structure of the HOT case before moving to the main two parts of my talk. Firstly, I'll give some tips on examination and presenting your findings. This component is deliberately brief, as those other resources I mentioned cover this better than I ever could. The bulk of my talk is going through how I suggest you prepare for the HOT case as you get closer to the big day, with insights I've gained from recently going through this process and tips from a previous medalist. I'll finish by taking you through a description of my actual exam case. This is the structure of the HOT case as it currently stands, noting that there are rumours it is likely to undergo significant changes in the coming year or two. You're examined on two HOT cases, which are real ICU patients in a real ICU. You're called from the room that you're nervously waiting in to outside the patient's bed space. You don your gown and gloves and you wait for your moment in the spotlight. You're given a piece of paper and have 2 minutes to read the stem. Then 10 minutes to examine the patient and 10 minutes to present your findings and be asked questions by the examiners. It's worth noting that 22 minutes is put on the timer and it isn't paused while you're taking off PPE and washing hands and getting ready to present. This eats up 30 to 60 seconds of your presentation time, and it contributes to the sense of rushing that occurs during the presentation. More on this later. So let's start with some strategies to use during the reading time, examination, and presentation. The stem you're given for the 2 minutes reading time looks something like this. The question can be anything, but the majority of cases are along the lines of either giving a list of issues or eliciting the cause of an altered level of consciousness, shock, respiratory failure, or fevers, and then giving a management plan. More specific questions include assessing readiness for extubation or completing a tertiary survey in a trauma patient. For me, the goal during reading time was to decide whether this is a neuro case, as it is in the example of an unconscious patient, where a detailed neurological examination is required and should be done first. This is in contrast to a patient with cardiogenic shock, for example, who is likely to only require a brief neurological exam, which, aside from the GCS, can be left until after the cardiorespiratory and abdominal examination. Every so often, certain types of patients may require a specific examination. For example, when doing a tertiary survey on a trauma patient, be sure to include thorough palpation of all limbs and the trunk and otoscopy. And when examining a pregnant patient, don't forget fundal height. As you get closer to the date, you'll start to expand your thinking during this time. For example, in a patient with an out-of-hospital arrest, you'll be looking for specific signs pointing to the cause of the arrest and examination findings that help you with neuroprognostication. Or, in this case I did, where I was asked to provide a list of issues and a management plan and comment on readiness for extubation in a patient 8 days post-subarachnoid hemorrhage who underwent PICA coiling. A better candidate than me would prime themselves to look for signs of a lateral medullary syndrome from the pica aneurysm and specific issues related to subarachnoid hemorrhage, such as pneumotopene, presence of vasospasm, or other complications like EVD-associated ventriculitis or seizures, as was the feedback from the examiner for that case. When there's 10 seconds left, just take a slow, deep breath. This is good practice for the day, where your mind and your heart will be racing. I'll assume you've all been through the examination section on deranged and various other reliable sources, so I'm not going to go through step by step my approach to examination, but before I make a few specific points, I'll display my summary on the screen for a few seconds, so you can pause the video if you're interested in reading it. A thorough but swift end of the bedogram is critical. Hot tip number 1 is to find all the clues. These can be crucial to passing the case. There are countless examples I could use. Usually it's an infusion of something specific, like clonazepam, levosimendan, tranexamic acid, or, in the actual exam case of a friend of mine, defibrotide, all of which can point to a diagnosis immediately. If you're suspecting a subarachnoid hemorrhage as the cause of an out-of-hospital arrest, then you notice the patient is on a heparin infusion, you'll quickly change your thinking to the cause being ACS or PE. The clue might be something really obvious, like an EVD filled with fresh blood in an unconscious patient, suggesting a subarachnoid hemorrhage or intracerebral hemorrhage with intraventricular extension as the cause. Or it might be something subtle, like NG feeds being at 20 mils per hour, but when asked, the examiners say the patient is tolerating them fine, suggesting that the patient may be at high risk of refeeding syndrome. Another example would be noticing a patient is ventilated on 50% oxygen, but with a PEEP of only 5, which might be a hint towards RV dysfunction. Think of yourself as a detective. Look on the trolley and even in the bins for empty medication packets. Signs such as these, or the presence of cytotoxic bins or a cooling blanket, can give you an issue to add to your list. This sign was at the entrance to the patient's bed space in a hospital where I did a practice case, which I noted was unusual, and the examiner made a point of asking me to wash my hands in the sink instead of using the Alco rub that I was reaching for. But unfortunately, I wasn't open to these clues as I failed to make the diagnosis of C. difficile colitis. Oh well, every mistake made in a practice case is a good lesson learned. I think in many cases, if your end of the bedogram is good enough, the rest of your exam can be average and you can still come up with a good list of issues. In saying that, your examination should look slick, like you've done it 50 times before, which you should have. Try to not stop, as this can give the impression that you're not sure what to go on to next. I liked to use the bulldog. I'd ask if they could please help me undo the gown or take extra sheets or pillows away to stop me fumbling around and wasting time. It is hard to achieve a happy medium between talking enough but not too much. I do a lot of speaking during the end of bedogram, but then minimal during the rest of my examination. And during this time, I try to direct most of my comments to the patient, not the examiners. For example, I say, "David, I'm just going to test your blink reflex with a tissue," instead of asking the examiner, "May I test David's corneal reflexes?" Asking the patient's permission to do something, noting that they may be unconscious and unable to answer, is my indirect way of asking the examiners, whilst maintaining the appearance that this interaction is between me and my patient, and they are merely observing. It also acknowledges the patient as a person, not just a piece of meat, and examiners emphasize that maintaining a respectful and dignified examination is an important aspect of the hot case. I just have a few points to emphasize about the presentation, but before I do, I'll show my summary on the screen for a few seconds again, so you can pause the video if you're interested in reading it. The first 30 seconds of your presentation can make or break your day, so hot tip number 2 is to open strong, because first impressions last. If the examiner gets the impression after your first paragraph that you really know what you're talking about and you've solved the case, they're likely to nod along and tick, tick, tick down their answer sheet. If your opening statement is poor, you have to put in a lot of hard work to recover. There are several different structures used. In all of them, I think answering the question in a direct way in the opening statement is essential. Then either the examination findings are presented as one block, then return to the issues and expand on each, or the relevant exam findings are incorporated into each issue. For example, a good opening statement might be, John is an elderly man in ICU for 2 weeks with multi-organ failure from intra-abdominal sepsis following a perforated sigmoid diverticulum. He isn't ready for extubation, the main barriers being his altered level of consciousness and poor respiratory muscle function and weak cough. The options are then, I'd like to present my examination findings and expand upon these issues further, where a system-by-system approach is used to present all exam findings, or structure number 2, simply dive straight into the issues. For example, I think his altered level of consciousness is most likely an encephalopathy from sepsis or organ failure, as there is no meningism or focal neurology. But I'd like to exclude residual sedation as a confounder. Then I'd like to see his blood glucose, urea, ammonia, and CO2 to look for common causes of altered level of consciousness. Be aware that although the first type might be easier to do, you are likely to be interrupted midway through presenting your exam findings, unless this is done very quickly and concisely. More on this later when I tell you about my actual exam case. When asked to provide a list of issues, which is a common hot case question, I used to think about fevers, frailty, and the 5 failures, which covers most of the main issues in ICU patients. The 5 failures being cardiovascular failure, in which you should specify the type of shock, respiratory failure, either type 1 or 2, neurological failure, usually being either altered level of consciousness or seizures, acute renal failure, which may be on a background of chronic renal failure, or gut failure, such as ileus or obstruction. Of course, there are other failures, such as liver, bone marrow, and immune failure, but this didn't fit so well with my alliteration, and a longer list will be harder to memorize. I made up a few other cognitive aids, such as the acronym CHAT for the causes of altered level of consciousness with focal signs, SWINDLE for the issues to discuss in long-stay ICU patients, I'm a victim for the causes of fever in ICU patients, or the mammoth greatest escape for the causes of altered level of consciousness without meningism or focal signs. All of these provided cognitive shortcuts and helped anchor my brain during stressful cases when my mind was racing. Using the right language during your presentation is critical. Use ICU lingo like multi-organ failure, mixed cardiogenic and vasodilatory shock, oliguric renal failure, hyperdynamic circulation, refractory status epilepticus. This will make you sound like an ICU consultant and fill the examiner with confidence that you can be trusted to look after their patients. I always try to paraphrase. For example, instead of repeating the exact age, day of admission, and presentation from the STEM word for word, I say a middle-aged man or an elderly man, and I say in ICU several days or a long-stay patient if they've been there over a week or two, to display that I have synthesized the case. I think using more than 1 or 2 sentences to tell the examiner what they already know, i.e. the patient's age, background, presentation, and question they've asked you, is wasting valuable time during your presentation. Be confident. Part of speaking like a junior consultant is using phrases like, I would do this, as opposed to how your registrar might say, we could do this. Finally, when interpreting investigations, use phrases like, this confirms my suspicion that Bill has suffered a high-grade subarachnoid hemorrhage when scrolling through a CT, to give the examiner further evidence that you're a strong candidate. It's also okay to use phrases like, this is an unexpected finding, if you note a chest x-ray has lobar consolidation in a patient who you said had equal vesicular breath sounds on minimal ventilatory support. So that's the end of part 1. It's all about convincing the examiners that you're ready to be a consultant. That means during the examination, you have to walk the walk, and during the presentation, you have to talk the talk. Now, I'm going to go through some tips on how best to prepare during the 6-month lead up to your hot case exam. Hot tip number 3 is to do at least 50 practice cases. This might seem like a lot, and it is. And it's true that many people have passed with fewer, but a motivated candidate is likely to do about 20 in the 6 to 8 weeks leading up to the exam, and ideally do the first 10 before the 6-month mark, which means that you only need to do about 1 or 2 a week for most of the 6-month period until the ramp-up time. You'll find that every 10 or so you start to perform at a higher level. For the first 10, it's normal to feel like you have no idea where to start and feel like you'll never reach the level required for a pass. If you don't feel this way, you're probably the next medalist, or you have a sense of optimism that most people can't match. It's good to get these 10 done before the 6-month mark, so you can be in the rhythm of things for the final 6 months. The second 10, you'll be more comfortable with the structure, and the third 10, the examination will become automatic, so you'll be thinking about the findings and how they fit in with the big picture, instead of thinking about the next part of the examination. After 30, you'll be looking at all the shortcuts and tricks, like noticing the signs. You might see a patient with a VASCATH, then you exclude every possible indication for dialysis, after which you hopefully conclude that the VASCATH might be to facilitate plasma exchange. You'll have several cases of assessing readiness for extubation in pathological airways, and you'll develop an approach to this. These are a few examples of why you have to do around 50 cases to be prepared for whatever the day brings. During this time, you'll need to develop a thick skin and be able to take negative feedback in a constructive way to improve for next time. Although it can be tough, try to be receptive of these comments. This is essential to improve your performance and ultimately pass. Tip number 4 is to channel your inner teenager and keep a diary. Some people decide to write out each case word for word as a sort of model answer to refine the structure and the exact phrases of their presentation. Though I see the merits of this, it's very time consuming, and so instead I just chose to write down some key points I learned from the case, mostly things I missed or didn't do well. All the handwritten notes in this presentation have been photos from my hot case diary. Like this, where I use the word delirium, and I was told during the feedback session that encephalopathy is a better phrase to use, as delirium implies that specific causes such as alcohol withdrawal, hepatic encephalopathy, and uremic encephalopathy have been excluded. Since then, I tried to avoid using the word delirium unless these other causes had been excluded. This concept is known as deliberate practice, which I first heard when I read a book called Peak a few years ago. Deliberate practice aims to improve performance by focusing in on a specific component of a skill with unwavering attention, instead of just repeating the exercise over and over again until it becomes almost mindless. For example, during the final 30 seconds of reading time before starting my examination, I would be thinking, don't forget to put the bed rail down and ask about urine output if during my last case I had forgotten about these things. If you Google deliberate practice, you'll find things like this, and you can learn more about this concept. It's 6 weeks until the exam. You've done about 40 practice cases. Now treat every one of your last 10 or 20 like it's the real thing. This might sound a bit unnecessarily harsh on myself, but when I made a dumb mistake, for example, if I forgot to ask if there had been any fevers in the past 24 hours, I was angry at myself, and I made a silent promise that I wouldn't make such a silly yet crucial mistake again. This is also a form of deliberate practice. Training tough means seeking out feared and highly critical examiners. Be confident that you can get a pass even from them. Look for the hardest cases, awake neuros, locked-in syndrome, triple valve replacements, diagnostic dilemmas. Be confident that if you can't work out what's going on, then the examiners probably don't have the answers either. Visit as many other hospitals as possible to do practice cases with as many different examiners as possible, and treat every single one like it's your actual exam. Make sure you visit the unit your exam is in about 4 weeks before the big day. Do a practice case or two. It might even turn out to be with an examiner you have on the day. Interrogate their ventilators, monitors, pumps, dialysis machines. Be sure to not leave it too late as they will go into quarantine and not let external applicants visit from about 2 weeks out. In the week leading up to the exam, the main priority is to end on a high, whether that is 7 days out or 3 days out, or any time in between. When you strongly pass a case during this time, that should be your last one until the exam. Other than that, control what you can during this time to optimize your frame of mind. You shouldn't be rostered to night shifts. Try to not have too many commitments or other things weighing on your mind. Eat and sleep well. Exercise, meditate, or practice mindfulness if you enjoy that. It may sound to you like you've strayed away from a presentation about preparing for the ICU fellowship exam and into a well-being seminar, but I truly believe that these factors play into your performance on the day, and they may be the critical difference between passing and failing. Once again, it might sound a bit wishy-washy, but I truly believe that optimizing your state of mind at this time is critical to getting through the hot case. All your practice can come undone if you lose this psychological battle. The evening before, make sure that anything which is modifiable is in your favour. I suggest you book a nice hotel. Even the best place is much cheaper than paying to sit the exam again. It should be very close to the exam site. I chose to leave my kids at home to free up my headspace. Consider a massage the afternoon before. Be prepared for the nerves to be building at this point. It is difficult to simulate this. The day of the exam, the nerves will be building. I found it useful to wake up with a few hours spare to have a walk and swim in the hotel pool and a light breakfast. You have to walk the fine line between enough coffee to wake up, but not so much that you regret it when your heart is racing as you're called to the bedside. To eliminate the stress of traffic, parking, and finding my way around the hospital campus, I took an Uber and arrived almost an hour before my start time. It's commonly said that the bar for passing the hot case is that the examiner feels like they can hand over their ICU patients to you on a Friday afternoon and come back Monday morning feeling as though they were in safe hands. That sounds very simplistic and it almost downplays the huge effort needed to pass the exam. But I do think it's true. To give this impression, you have to examine, think, and speak like a consultant. As I've already mentioned, that means the examination is smooth and without pauses. Life threats and other big issues like timing of tracheostomy and prognosis are raised. And you are able to commit to some decisions and give reasons why. I want to tell you about one of my 2 cases from my exam because it illustrates these points and it shows that things might not go in the direction you suspect and you have to stay flexible and be able to bounce back from interruptions. My case was a young man with an isolated severe TBI with multi-compartmental hemorrhage from a push-bike accident without a helmet. I was asked to list the issues and come up with a management plan. In both of my cases that day, I was interrupted halfway through presenting my findings with an abrupt, "How are you going to manage this patient?" The pace of both these interactions and the intense feeling of being rushed is something that is difficult to describe. I had never been interrupted during my exam findings in a practice case, but I had, fortunately, had my fair share of stress inoculation during these months. I said aside from managing the TBI, it was key to exclude other traumatic injuries which weren't evident on examination. I was told there were no other injuries. So I started down the long road of listing neuroprotective measures for TBI management, such as targeting a certain sodium, CO2, and I was promptly interrupted again. We'll come back to all of that. What's your approach to chemical DVT prophylaxis in this patient? Well, this would usually be directed by the neurosurgeons who they're letting you make the decision. Then I would do a follow-up CT brain at 24 hours, and if there's no extension of bleeding, I'd look to start BD heparin at 48 to 72 hours. Having lost my way from my usual presentation format, I tried to start again, saying something about neuroprotective measures. What's your approach to feeding in this patient? I was once again interrupted. I'll start trophic feeds at 20 mL per hour now and up titrate as per the unit's NG feeding policy. There is no policy. It's up to you to decide, the examiner said. I'll increase by 20 mL per hour every 4 to 6 hours as tolerated, as long as aspirates are minimal. What's your approach to gastric ulcer prophylaxis, he asked. I would start 40 mg pantoprazole daily, and I'd consider ceasing this in 48 hours if he's tolerating full feed. Time up! Thank you, candidate 242. I felt like I'd just gone 15 rounds with Mike Tyson, and little did I know it was about to happen again in half an hour for my second case. I presumably didn't score a strong pass, but I feel that the reason that I passed at all is because I was able to make a sensible decision at the level of a junior consultant when put on the spot about everyday ICU issues. You must get used to being interrupted, redirected, and challenged. For my last point, I decided to ask my friend Alice, who won the fellowship medal in 2020, what advice she had for exam candidates. She mentioned a few things similar to me, like having a strong opening statement that shows that you have understood what you are asked to do and you've come up with an answer, using phrases like, I would do this because, making your last practice case a strong pass, and being receptive of feedback. She had a few other pearls of wisdom, like looking at past papers to see the type of stems you're likely to get, and treating your ward round as an opportunity to practice your routine of introducing yourself, putting the bed rail down, exposing the patient, assessing the bed space, then examining. Don't verbalize everything you see, but mention anything interesting or unusual so the examiner acknowledges that you find it noteworthy, just in case you forget to mention it during your presentation. Practicing how to recover from interruptions or saying the wrong thing is really important. Many candidates have come unstuck by digging themselves into a hole that they can't get out of. Just say something like, I'm sorry, that's not what I meant. What I meant was this. Similarly, don't make things up. It's okay to say I don't know, which gives a sense of humility and integrity. It's unlikely that the question they're asking you is pass-fail for the entire case. Learn the automatic fails, for example, doing a neuro exam on a paralyzed patient or doing something unsafe, like applying a painful stimuli to a patient with an elevated ICP. When asking for bedside tests at the end of the examination, specifically state what you're looking for, instead of waiting for the examiner to ask you. And finally, Alice used to practice presenting her cases in front of the mirror, instead of writing a diary of cases, which is another form of deliberate practice. That's all from me today. In closing, I want to emphasize my 5 main tips. During your walk around an examination, find all of the clues. When you start presenting, open strong using ICU lingo and include an answer to the question in your first sentence. Remember fevers, frailty, and the 5 failures when you're trying to come up with a list of issues. Try to do at least 50 practice cases and keep a diary of them to utilize deliberate practice. Train tough and be confident. You're ready to be a junior consultant. I hope this was helpful. Good luck in your exam prep, and please email me with any questions or comments.